Welcome back to PedsCrit. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C.
Alice, will you remind us what we do here at PedsCrit?
Absolutely. PedsCrit is an educational PICU podcast. We're looking for the best pediatric ICU bedside teaching pearls around the country and the world, and we're getting them recorded for you. Zach, who are we talking with today?
Today, we have the pleasure of speaking with Dr. Michelle Kittleson. Dr. Kittleson is the Director of Postgraduate Education in Heart Failure and Transplantation, Director of Heart Failure Research, and Professor of Medicine at the Smidt Heart Institute at Cedars-Sinai. She received her MD at Yale University, School of Medicine, followed by residency in internal medicine at Brigham and Women's Hospital, and fellowship in cardiology at Johns Hopkins, where she also received a PhD in clinical investigations from the Johns Hopkins Bloomberg School of Public Health.
Yes, Dr. Kittleson is also a guideline author. She was the chair of the writing group for the 2020 AHA Scientific Statement on Cardiac Amyloidosis. She co-authored the American College of Cardiology's 2020 Hypertrophic Cardiomyopathy Guidelines, and she co-authored the American Heart Association's 2022 Heart Failure Guidelines. But today, we are not talking about any of these guidelines because we work in the pediatric ICU. We are talking about running efficient rounds.
That's right. Dr. Kittleson has several great skills to share with us during this episode. Everything that we discuss is also included in her book, Mastering the Art of Patient Care, which we will be sure to include in our show notes.
Yes, let's get right to the interview.
Welcome back to PedsCrit. We are so excited to have Dr. Michelle Kittleson with us here today on the podcast to discuss this very important topic. Dr. Kittleson, to get things started, will you tell our listeners a little bit about yourself and include something you enjoy outside of medicine?
Sure. So I am a heart failure transplant cardiologist at Cedars-Sinai in sunny Los Angeles, California. And one thing I really enjoy doing in my free time is volunteering at a wild game preserve. Does that sound strange? It actually is strange. That's awesome. There's only 3 wild animals there. They're all boys, and they happen to be ages 10, 7, and 5, and they actually live in my house. So nice. When I'm not at work, I am wrangling these wild animals, also known as my wonderful children. And that's pretty much the greatest hobby of my life.
That is awesome.
How did you become interested in heart failure and transplant? And because you are an MD PhD, I would love to hear what area of research you're most excited about in the field.
Oh my gosh. Well, let me start with the MD PhD question because so let me tell you why I got the MD PhD. Okay, so here I am in medical school, just loving clinical medicine, taking care of patients. Here I am in residency thinking taking care of patients is the most wonderful thing in the world. And at the end of residency, I meet with my mentors. Mentors are a great theme in my life, as I'm sure they are in yours, guiding me in so many ways. And I met with one of my mentors and said, I want to be a cardiologist, but I don't like research. I just want to take care of patients. And this incredible mentor to me, sort of a national leader in clinical medicine, said to me, you know what? You got to do some research and you got to do it in training because you can never go backwards. You need to get it done and then you can truly decide if you've done it, if you like it or not. And I said, okay, I'll take your advice. So I went to start cardiology fellowship. And at my program, there was an option to get a PhD during your cardiology fellowship in clinical investigation. So focusing on things like biostats and epidemiology. So you do 1 year of clinical cardiology fellowship. The second year you take classes. The third year you do research. The fourth year you'd finish up your clinical work and defend your thesis. And it's quite a luxury, actually, after you've been in training for so many years to go back to the classroom. So there I was as a second-year cardiology fellow, sitting in these classrooms with kids who were getting their MPHs. And I was like shushing them if they were making noise in class. I was just so excited to learn again in a classroom setting. And what I found is in my 2 years of clinical training during fellowship, I would sleep like so peacefully every night. I'd go to work, I'd do a good job, I'd try hard to take care of my patients. I'd go home, I'd get a good night's rest. On my research years, I'd be up at 2 a.m. Did that statistician do this? What did the reviewers say about that? I'm like, this is too stressful. My effort doesn't equal my achievement. I didn't have the mindset to do research. So I got the PhD because I felt like I had to give research a try and ultimately felt like it truly wasn't for me. I've never written a grant. When it comes to my research focus, it's very haphazard in the sense that I think of a question I don't know the answer to, and then in a resident or fellow and I look into it, like, how do patients with muscular dystrophy do after transplant? Well, let's look at our data. The kind of questions like that, not highly sophisticated, but I think very relevant. And then my academic work on a larger scale is more, how do we interpret the mountains of research out there in a way that's useful for clinicians? So I guess I'm sort of like a critic, like a movie critic, but I try to always like the movies and find good and constructive things to say about them. So it's a very long-winded answer to your question about what's the deal with the PhD. And then when it comes to why cardiology, it's very clear. Number one, the history and the physical matter. You can't diagnose unstable angina without a history. You can't diagnose decompensated heart failure without a physical exam. I love the fact that I need to talk to and look at my patient. Number two, I love the wealth of clinical trial evidence. If I'm going to give a patient a medicine, I have a lot of data to tell me why that medicine works. And number three, this is going to sound a little strange, but because the dying process of the heart failure patient to me is emotionally acceptable. Meaning when I did my rotations during residency in oncology, it was so hard to process the many terrible ways that cancer leads to death. And that's just my makeup, my temperament, my background, my experiences. But somehow I could come to more peace emotionally with that in cardiology. So those are the reasons why I chose the best field in the world for me, cardiology.
Wow. That's an incredible answer and also sounds like an incredible program. This was at Hopkins?
Yes. So Hopkins, I don't know if it's still, at the time, the fellowship was a required 4-year fellowship. I'm not sure if they changed it, and now it's 3 years, but you can take an extra year. It was a wonderful way to just immerse yourself in clinical medicine and really give research a try. And, I don't know if my former research mentors are shaking their heads now. We tried so hard with Michelle. It just didn't stick.
I mean, I don't think so. Well...
But it was such a great experience to really just immerse yourself in the experience and figure out if it's right for you.
Oh, absolutely. So you're also the fellowship program director, and you've literally written a textbook on patient care. How did you become so interested and put this niche together for yourself in education?
So I've always been so enamored of my mentors. I feel so much of medicine is an apprenticeship. Meaning you can read something in a book, but so much is unspoken or it's by observation. You see someone doing something well, or you see someone doing something badly, and you use that to form your own style. So I love that aspect, the apprenticeship of medicine. The second thing, being a program director, I tell my trainees, I'm your program director for a year, because the Heart Failure Transplant Fellowship is a year long, but I'm your mom for life, because I'm here, I'm interested, I'm invested, like I want your future to be great. And so when they text me pictures of their new houses or their new babies or their new fiancés, I mean, it's amazing. So that's part of this book, is I feel there's so much that is not taught in medical school that can't be taught in medical school. There's plenty of other things to learn. And so much of the doctor you become is shaped by the people you run into. I've had mentors who impacted my practice who I've worked with for a day and some who I've worked with for years. And for me, trying to put that together so that there's a handbook that you can reach to when you're not quite sure to do in this situation. And there's a chapter here where she goes through the mistakes she made and how she came out the other side. That could help other people as well.
Certainly really excited to learn more about your book, Mastering the Art of Patient Care. One more question for you, and this one actually wasn't scripted. So you've certainly been active in many different areas of open access medical education. Think about the various podcasts you've done, video interviews, and of course, your presence on Twitter. My question, has your involvement in these various forms of open access education, has that been intentional for you? Like, did you do this to further your career, or was it more just a follow expression of your success in other areas?
Yeah, it's funny. I have a colleague who told me that when she was early in training, maybe in medical school, she made a list of all the things she wanted to do in her life. And one was run a division in a major medical center and write a textbook. And I was like, gosh, I was just trying to survive medical school. And I mean, my only passion truly has always been, I want to take great care of patients. I want to take great care of patients. And what's happened to me along the way is I found that one of the ways to take great care of patients is to learn from my mistakes and those of others, and learn from my mentors and their experiences. So that's where Twitter came in. A few years ago, one of my trainees inspired me and said, you should be on Twitter. And initially I was a little nervous about this form of social media. And he sort of taught me. And then instead of ranting on rounds to 6 trainees, now I could spread my rants to the universe. And the reception to me was so enormously welcoming that it inspired me to say, okay, instead of just having random tweets, let's organize this philosophy into a very nice outline that will turn into a book. And so really all these forms of open access medical education, it's more that they've come to me and I found how much I enjoy doing it, because what you learn, at least what I learned, I don't know if this is good news or bad news, but the first 5 years as an attending physician are terrifying.
Yes.
But after that, I feel like you can take a deep breath and you're probably not going to see something you've never seen before. If you are, you're going to have an algorithm in your head on how to manage it. And then you can start to open your mind to what else is interesting. I don't have to spend so much time building my foundation of knowledge and experience. Now let me branch out and see what else I can do to make the job fun. And that's really where the educational piece came in for me.
Nice. Well, we really appreciate that. And I also appreciate the permission to focus on being a new attending first, because we also are fairly intimidated by that journey.
Yes, I believe it. I remember it. I lived it.
Now, besides your book, do you have any conflicts of interest to disclose before we get started on the topic?
No, absolutely zero, none, zilch whatsoever by design. I'm conflicted in no aspect.
Excellent. All right. So we're going to talk about our favorite thing, which is rounding. Before we get specific tips from you, you're a heart failure attending, you work in multiple settings. What does your rounding process usually look like? Do you have a fellow? Are your patients in one unit? Are they everywhere?
Yeah. So my classic rounds will be with a core group of a fellow and a nurse practitioner and me. So we cover, let's say, for example, it's the advanced heart failure service. So any patient in the hospital with advanced heart failure who will either be in the intensive care unit where we're consulting, or on the floors where we're consulting, or on our primary floor service. So those are the 3 areas. So if it's the consult on the floor of the ICU, then they're covered by me, my fellow and nurse practitioner. And the fellow and the nurse practitioner generally act in parallel, covering some of those patients. Then we'll move on to our own service, which is composed of floor patients admitted with heart failure, where we're primary, and we have our resident house staff taking care of them.
Gotcha. So both the primary attending and the consulting service that we work with in the CICU.
Yes.
Nice.
So rounds is certainly an important part of the day for our patient care, but also educating our trainees who are coming alongside us. How do you set goals for rounds to make sure it's meaningful for everyone involved?
Yes. So I always tell the trainees that we have 3 goals on rounds. Goal number 1 is outstanding patient care. Goal number 2 is efficiency. And goal number 3 is education, not because it's the least important, but because if you take outstanding care of your patients and you do so efficiently, you will learn. And that is why those are my priorities. And I think didactic lectures are the worst way to learn. I'm glad we have them. I think we need them. I think it's also a nice break in the day just to sit down and have someone talk at you. That's good. But I think the patient-directed pearls on rounds are the best way to learn.
And specifics on timing, like, do you have a goal like, gosh, we need to be done by 11:30 to keep everyone sharp, or how do you?
Or 9:30.
Yes.
How do you practice?
Yes. So we start at 7:30 a.m. 7:30 a.m. start is when I meet with my fellow and nurse practitioner in the intensive care unit. We'll go through the intensive care unit patients, the consult patients, and we're done by 8:30. And that means that with those patients, so we've seen the patients, we've run through a list of our plans, we've discussed with the primary teams on those consult-related patients. And then by 8:30, we meet with the residents. And by 8:30, when we meet with the residents, the fellow and I have already run through what we believe the plans are on the patient, so that we have maximum efficiency once we get to resident rounds. And when we get to resident rounds, COVID changed it a little bit in that we used to do walk rounds and go into every patient's room, but then we're like, whoa, going in with, 10 people to every room, that's a great way to spread Acinetobacter or COVID or who knows what else is out there. So we've done more card flipping rounds. And then if someone's got the most amazing jugular venous pulse that everyone has to witness the beauty of this, we'll do more physical exam directed focused rounds in that sense. How do I structure resident rounds? So it's 8:30, we'll start. And they generally cover 20 patients, this resident team, with 2 separate attendings because there's the heart failure and then there's the transplant teams. So I know that when I meet with them at 8:30, and I usually slip in first. So when I meet with them at 8:30, they're probably going to be rounding until 10:30 or 11, but not with me. So we try to keep it as streamlined as possible to take an hour to do our patients. And the way we make it efficient and so that you don't sort of get burned out of the constant talking is number one, it's a one-liner and straight to plan by system. And sometimes I tell the trainees, you might worry if you're not speaking as much, I won't be able to evaluate you. I won't be able to tell you how good you are or bad you are. You know what? The less you say, the more I hear. So it's actually an art to say things succinctly. So number one is one-liner plan by system. The second thing to make things efficient is I have already reviewed everything about every patient. There was a resident once who said to me, the weird thing about Kittleson is she knows more about the patients than I do. You can't out Kittleson. And I said, well, that's the goal. I'm the attending physician. I'm the bottom line. I gotta know everything. That's my responsibility to my patient. Doesn't mean I say everything. And I know you're giving me the plan, but I always know what's going on before you say it because that's my job. So that's the second thing I think keeps rounds efficient. And then the third thing I'd say is to know your teaching points ahead of time. So I'll have a sense when I'm reviewing the chart, this patient has a bump in creatinine after we started the SGLT2 inhibitor. That'll be a really nice thing for me to ask. And I carry, I remember when I was pre-rounding as a medical student, every patient got a page of paper. And then when I was pre-rounding as a resident, maybe they got like an index card. And then now as an attending, they literally get like one box, like at one line and then one checkbox, because I can encapsulate everything so well. But those are the things. So one-liner plan by system, I already know everything that's going on and have some teaching points prepared. And I think that keeps things very vibrant and moving and patient-focused, but still with an educational piece.
It's evident that you're putting in a serious amount of time prior to rounds to optimize things for your learners. And I just commend you for that because it's intuitive to me that they're having a great educational experience because of the time that you're putting in before you even show up on the floor. I'm curious about how you can coach your residents into making a good assessment of their patient if they're only doing a one-liner in a plan. Will you tell us more about that?
Well, I think the one-liner is so critical. It is so critical because let's talk about a good one-liner versus a bad one-liner. Patients, admitted with heart failure. A 59-year-old woman with a past medical history of hypertension, hyperlipidemia, gout, appendicitis presents with heart failure. I'm already confused. I'm like, do I care that they had appendicitis? Is this what's going on here? Why? Or and hypertension and dyslipidemia, is it an ischemic cardiomyopathy, a non-ischemic cardiomyopathy? If they have cardiomyopathy, why do they have hypertension? It's a hypertensive cardiomyopathy because patients with hypertension usually don't get cardiomyopathy. So I'm all confused. I'm already so distracted. I can't hear another word they say. As opposed to a patient with a past medical history of poorly controlled hypertension resulting in a hypertensive cardiomyopathy and current ejection fraction of 25%, presents with 3 days of progressive dyspnea and exertion admitted with decompensated heart failure. You know everything you need to know. So the first thing I will do is I'll often say, let's redo the one-liner. And then every morning I want that one-liner because I feel like that then inculcates into their brain the right relevant pieces to think about a patient. So that's the one-liner issue. The second is how do you get them to think about an assessment? It's so interesting. I work with these amazing fellows, and often I let them run rounds. Mm-hmm. And then I'll just kind of swoop into the end with a few teaching points, or if I think things are going just a little bit off the rails, kind of bring them back in. But it's funny to me how I remember being a fellow or a junior attending, and when the resident got something wrong, just swooping in and just correcting them. Enough already. And now I can see as an attending how to just ask a question. So they're like, of course that's the right answer. So for example, the resident will say to me, so the patient made 2 liters of urine, continue Lasix. And then they move on to the next. I'm going, whoa. Is the patient wet, dry, or in the middle? That's my favorite line. Wet, dry, or in the middle? And then they say wet. I'm like, why is the patient wet? Because I actually think the patient's dry. Well, their lungs are clear. Are clear lungs actually useful? So you go through so many, like, how did you come to that decision? And then when you get the assessment right, okay, so now you think the patient's wet. Okay, I agree with you, the patient's wet. You've told me why the patient's wet. Are you happy with how much they peed? Well, they peed 2 liters, but how much did they take in? Were they negative? Did their weight go down? What do you feel about the fact that their weight went up, but their ins and outs went down? Which one do you believe? What do they look like? And so kind of, and not in a, I feel it's very collegial. You know, it's all fun. It's like, let's come up with a plan. This is so exciting. And when they get to the answer, it's like, fantastic. And then, okay, you want to increase the Lasix. What are you going to increase the Lasix to? And they're like, they're on 40 IV BID. I'm going to go to 60 IV BID. And I'll say, sure, though inwardly I'm cringing. Because there's a rule in cardiology, you always double the dose. I don't know why. The kidney knows it must be doubled. But, you know, so you also have to pick what are you micromanaging and what are you allowing. But then I'll make a contingency plan because I just know in my heart of hearts that 60 IV is just not going to cut it. I don't know why. I just know. So I'll say to them, all right, you can do your 60 IV BID. But if you don't get X result by X time, what are you going to do next? And then you make a contingency plan. So I love that sense of the if-then statement to really help you organize your thoughts. I mean, one thing that no one is ever allowed to say to me on rounds is, consider X, Y, or Z. Consider, what are we? Who are we? We are making a plan. We are making a decision. And so the if-then statement is a great way to phrase that.
I really like the idea of providing contingency plans so you can enable your learner to see the results of their decision. And I feel like that'll be much more meaningful for them when they come back to a similar scenario in the future.
Do you do anything to minimize your interpatient interval when you're rounding, or the time that it takes to get from point A to point B?
Yes. Oh, that's a great question. I love that question because I actually have this joke on rounds that I make all the time. So at Cedars-Sinai, generally, the heart patients are usually on the 4th floor or the 6th floor. Mm-hmm. And then every so often, they'll sprinkle in a 3 south or a 5 north. And I look at our list and I look at my team and I say, the feng shui is all wrong today. We are going to spend so much time traversing between units. We are going to lose 15 minutes of our day. And that adds up. 15 minutes in the morning is worth 4 hours by the end of the day. So how do you minimize that? You just ignore those patients. No, we don't just ignore those patients. But you know, you're absolutely right. You have to use every minute of rounds wisely. So I actually find the whole discuss all the patients at once in a given unit, then go see those patients actually works much better than the discuss, see model. Because I think when you're in the groove of presenting patients, that actually flows more smoothly, and you're still going to remember the plan when you go talk to the patient. So the other thing is, yes, we get going for the far-flung empires of Timbuktu, and then we're going to Siberia, and all these places in the hospital, is if you are in a hallway and there's no, other staff around, it's a deserted hallway, or if you're in an elevator all by yourself with your team, run the list. What's next? What do we do next? I think that's hugely important to just use every moment wisely while you're together. So that can minimize it. And the other sort of side note for efficiency is when you're in the middle of rounds, it's nice to have a person assigned, of course, to write the orders, right? Because someone's sitting by a computer inputting the orders while the other person's talking. But in addition to call the consults right then, right there on rounds. Don't wait to the end of rounds. Consultants have lives too. They'd rather know earlier in the morning to get the ball rolling.
Ooh, I like that. And I feel that might be actionable to me to say that early, to be like, feel free to call the consults.
Yes.
Today we're rounding long. It might be 10:30 a.m. by the time we finish.
Yeah. And there's so many, every hospital has different styles, and some probably use pagers. Some just text people directly. Some of the Epic secure chat. There's so many efficient ways to not disrupt rounds, but get the consult in. Yes.
Yes. So you are the heart transplant attending on the primary heart transplant service. Your team has a heart failure fellow and 3 residents. You, for whatever reason, 8:30 comes, you're starting rounds. You haven't had the opportunity to give your introduction spiel. You have a trainee that gives an excellent one-liner, followed by a detailed account of the overnight vital signs and morning lab data. You appreciate her attention to detail so much, but you think that she could save some time by changing her presentation. How do you pivot that scenario? Do you wait until the end individually? Do you do it in person? What's the best practice here?
Yeah, great point. I think the larger question sort of is when do you interrupt and when do you not interrupt, right? When a trainee is speaking. So I think there's times to interrupt and there's times not to interrupt. So if it's something sort of simple, like, oh gosh, you didn't get Kittleson, no one told you the Kittleson style of rounds, and somehow, you're covering for the day and no one told you and I didn't mention it. As soon as they start with the T-maxers, I'm like, oh, that's okay. No, it's okay. I literally jump in at that moment. Because if you let that poor, lovely trainee get through all that stuff and then you tell them, they're going to feel kind of like, oh, geez, why did I just say all that stuff when no one wanted me to say it? So I'll say, don't worry. You've already looked at the objective data. We've already looked at the objective data. You jump straight into that plan. And it's funny that many trainees are just so conditioned because every other rounds in the hospital goes the long way. Often I'll have just to keep reminding them, straight to plan by system, straight to plan by problem, whatever you prefer. So I will often interrupt when it's something minor like that. The other time I'll interrupt is if I feel like they've got the assessment really opposite to where it needs to be. Meaning, I think the patient's wet and they think the patient's dry. I think the patient is poorly perfused and incipient cardiogenic shock and they think the patient is doing great and ready. So if there's a really fundamental difference, then we start the questions to how did I figure out that this is the assessment and how do I help convince you to figure it out? The time when I won't interrupt is when, it's okay. It's like, you want to go up on the carvedilol to 9.375. And I'm like, gosh, 12.5 is just easier. It's not so many decimal points that we have to say every morning on rounds. And then I might wait till the end and say, okay, I'm happy with your way, but consider this. So I think the times to interrupt when it's just so minor, but it'll take a long time if they keep going, or if there's a fundamental misunderstanding. And now when I was a trainee, I did not enjoy being interrupted at the end of everything I said with a little oh, and I found that broke my flow. In fact, there was one time as an intern, I remember saying, thank you so much. I'm going to get to that in my next problem because I was post-call and I was salty and I'd had enough. And so I try very hard not to interrupt flow unless it's fundamental.
Oh, that's very fair.
I think it's a really good strategy to not interrupt the trainees because if you do it over and over again, I feel like they start proposing every plan as a question. Like, are you okay if we go up on Lasix today? Are you okay if we set a goal negative 150 or something? For, I guess, babies here. Pediatrics is coming out. So I think it's really clever to do. How do you...
And you're so right because sometimes you find that then they start pausing to wait for you to speak. And then I'm like, oh, I must be interrupting too much. I don't want them to pause. I want them to keep going because you're right. They are hopefully the captain of the ship and owning their patients. Yes.
Sure. And we'll certainly get to that nomenclature shortly. Do you find it helpful to just go ahead and have like a day one of rotation? I'm setting expectations, or does it happen more organically for you?
Oh, no, I will say on the first day, again, my 3 goals are outstanding patient care, efficiency, and education, because education will happen if the other 2 goals are met. And we will do Pearl-based teaching with 1 or 2 didactics a week, depending on time. And there'll be chalk talks, so they're super informal. And one-liner planned by system. You know the objective data, we know the objective data. Let's not waste the time. Let's go straight to what matters to help us care for the patients.
Excellent. Well, now it's Wednesday with your team. It is the second day of admission for a heart failure patient who is admitted for diuresis. You suspect that the patient is still hypervolemic. In her assessment, your trainee says that she suspects that the patient is hypovolemic and requires some additional fluid back. After you've discussed this sort of in the assessment, your trainee mutters something about nephrotoxic medications and fragile kidneys. How are you using this captain, waiter, toddler framework that you've written about to really pivot the situation?
Oh, I love dissension and disagreement. I love healthy, respectful debate on rounds. I love it for many reasons. I love it because, number one, it means that the trainee has an opinion, which is so critical when you are in training. To fashion your own clinical judgment, you have to have an opinion that's sometimes right, sometimes wrong, and then you learn. Number two, I love it because the trainee feels comfortable enough, even in a quiet, perhaps subtle way, of showing their unhappiness with the plan. I mean, they're invested in the patient. They want what's right for the patient. I appreciate that passion. And number 3, I love it because I think in the world in general and in medicine in particular, it is a team sport and we have to learn how to get along even when we disagree and to come to consensus. You know, I sit on the Heart Transplant Selection Committee, and it is an extraordinary exercise in building consensus when there are disparate opinions about what's right for the patient. And I think that practice is never wasted in any part of life. So I will call out the elephant in the room. You know, as physicians, we're very good at reading facial expressions. I don't know about babies, how you guys do that, but at least for adults, it's very good at reading facial, even with masks on, that subtle tightening around the eyes. They're not buying what you're selling. And I'll say, hey, I don't think I've convinced you. Tell me why this plan does not feel right. And if the trainee says, well, the creatinine's rising. Creatinine's rising because they're dry. I'll say, is being dry the only reason why the creatinine dries? Great, you can be intrarenal, prerenal, postrenal. And so you don't think they're postrenal, right? We know there's no obstruction. They got a Foley in. You don't think it's intrarenal because you didn't slip them some contrast or NSAIDs. I said, okay, so it's prerenal. Well, can you only be prerenal because you're dry? Or can you be prerenal because you're too wet? Can renal venous congestion precipitate worsening kidneys that improve with diuresis? Okay, but I don't believe they're wet. Okay, how do we tell if someone's wet? We look at the JVP, but the patient's got TR, so I know the JVP is always high. I'm like, really? Can you ever have a normal JVP when you have TR? Can TR be a dynamic valvular lesion such that it's volume sensitive, and as you diurese them, it gets better, and so too does it? And on their last admission, didn't I, in fact, document a normal JVP by the time of discharge? And in fact, the echo that we got on discharge showed the TR was minimal when they were euvolemic. And so that's kind of how you can work through the problem. But I adore the debate. I think that is so critical. That's how I learned as a fellow, as a resident, as a trainee. And it sort of builds into that toddler, waiter, captain model I put together a few years ago, where, a toddler, this will apply to the pediatricians, right? And I've had toddlers, so I can speak from experience. Toddlers just want what they want when they want it, and they're right, and everyone else is wrong, and everyone better get on their train. And I think those moments are kind of born of fear as a trainee, like I have to be right because if I'm wrong, something bad could happen to a patient. And I think those you meet with understanding. Let's figure out why this is wrong. Let's accept that it's not fun to not be correct, but what's a constructive way to turn this around? The waiter is the one whose fear manifests not as rebellion, but as subservience. And so I have the story of I was in the cath lab one day with a fellow, and one of the teaching points when you're doing a coronary angiogram is what catheters do you use for what patients. And sometimes it's what catheters were used on the last angiogram for a patient who happens to be a heart transplant recipient who's getting serial angiograms, like their aortic root is a little small, so you use a different catheter versus large. And I knew, because I had prepared, that the prior year we'd use special catheters for this patient, so I wanted to have those ready. So I walk into the cath lab and I say to the fellow, what catheters should we use today? And he said, whatever catheters you want to use, Dr. Kittleson. And I said, no. You may kiss my feet as your feared supreme leader, but you must have an opinion about what catheters to use. You must know what catheters you need for the patient. So you have to push the waiter out of the comfort zone. So my favorite question, whenever a trainee says to me, what dose would you like, Dr. Kittleson, is what dose would you like? Always put the question back on the waiter. Put it back. Let them know it's a safe space to be right or wrong, but have an opinion. Let's work it out together. And then the captain, of course, is the ultimate goal. Your job is to create captains, to empower your trainees to have a safe space, to have a plan that may be right or may be wrong, but regardless has a rationale, because then you can gain experience by learning where you were right or wrong.
Excellent. And I have to recommend now, I do have to recommend reading the article. And it's not because you'll phenotype your trainees, but it's because when I am the frontline provider in the cardiac ICU, I have one thing in my head, and it's be a captain, be a captain. You are the captain, be a captain. Don't be a toddler, be a captain, you know? And so I think that personally, it's a useful framework, even if you're not looking outward.
Yeah, thank you.
All right. So we've talked about the captain, waiter, toddler framework. And you've mentioned this a couple of times, but is there a time during rounds where you think this is where I'm going to add a formal teaching point? You know, the study came out last month. I'm just going to say something about it in this time on rounds.
Yeah, I try to often close out at the end of a patient, like, what can this patient teach us today? And not necessarily every patient, because listen, we've got a finite time on rounds. The longer you're in a field, I think you realize what the low-hanging fruit of the common myths are and the things you want to dispel and the pitfalls. And so you want to help trainees get through those. So in heart failure, it's, you can't trust the JVP in someone who has severe TR because it's a volume-sensitive lesion and it may improve with diuresis. Or if someone's creatinine is rising, the first step is to slow down diuresis. No, the first step is to look at the patient. Or how do we titrate up guideline-directed medical therapy? Which ones are detrimental with rapid aggressive titration? Which ones are actually beneficial because they have acute hemodynamic in addition to long-term mortality benefit? You'll know in your field what those salient points are. I mean, you do rounds over and over again. You know where people trip up, and that's where you have your points. And I would say the other thing too, you can always remember, gosh, what did I always get wrong when I was taking care of a patient like this? And then share that teaching point with trainees. Because we all sort of go through the same process, and I think that's very helpful.
You said earlier that you round with fellows, especially in the ICU and on the floor. And I would imagine an emphasis for your training is empowering them to teach residents on rounds. Will you tell us maybe some common pitfalls, maybe not so good strategies that fellows may sometimes use for teaching on rounds, and maybe some pearls, some things that we should lean towards doing?
Well, I'll tell you from my own experience as a fellow when I did things not so great. So I remember there was a review from one of my attendings when I was a fellow, and I still remember it word for word because it hurt me so much. And it was, Michelle is overly controlling and prescriptive of the house staff. I was like, what? That cannot be true. We must have written about the other Michelle. There was no other Michelle in the training program. But you know what? Then I looked deep within, and I wish the feedback had been a little more specific. I wish it had been in person and not just written feedback 2 months after the rotation. I wish I could have gotten more about it. I actually knew who wrote it, even though at the time all these things were anonymous and I was too intimidated to go ask for more detail. So a lot of things about this feedback situation were not great, which I cover in my book about better ways to give feedback. But what I'll say is, when I looked deep within, I thought there was a pearl of truth there, in the sense that the best way to teach is to give trainees a chance to be incorrect and a safe space to do it so that they can make their decisions, so you don't swoop in too quickly. And I think sometimes there's a temptation when you finally know something, you're a fellow, you're early attending, you know stuff. Plus, you feel much more, especially as an early attending, a sense of ownership and responsibility, like, oh my gosh, nothing can go wrong for this patient. I'm the bottom line, to jump in prematurely. Mm-hmm. But I think what's important to realize is what's negotiable and what's non-negotiable, right? Forgetting to give heparin when someone's got a mechanical mitral valve and atrial fibrillation and they aren't subtherapeutic. Okay, bad. That's non-negotiable. Come on, let's go. I'm going to interrupt you. We got to get this going right now. As opposed to, well, I could go up today or I could go up tomorrow. So I think that's the point, is figuring out what's negotiable and not negotiable and giving them a little bit more time to speak before you jump in. I see that with myself in the cath lab. When I was a first year attending in the cath lab, I would literally have sweat beating on my brow when the fellow held the needle. I'm like, I am not controlling the needle. I don't know where the needle is going to go. But then as you get farther along, I was just in the cath lab yesterday with a fellow, and it's like, you can just tell after 17 years of experience by the way the fellow holds the needle if the patient's going to be okay or not. And if the patient's not in pain and the patient's not in danger, let's let this unfold and allow the experience to happen. So I think that applies also to giving pearls. So I guess my 2 pearls for those early career, when you're teaching those junior to you, is give them enough time to get their thoughts out. Don't jump in too soon, but know what your own non-negotiables are so patient safety and care is never compromised.
Mm-hmm. Mm-hmm.
And it seems like there's a theme of always maybe having an idea of what you want to say, but even before you say it, having those teaching pearls in mind on rounds, and always leaning towards efficiency. We should never have our trainees or our kind of standing around, shuffling their feet.
No.
Yeah. I don't want to say bored, but certainly distracted.
Yeah, I mean, listen, the day is so long for trainees. The day is so long. And so much of the day, right? The surgeons make fun of us for a reason. So much of the day is spent rounding. But really what we need plans. We need plans for our patients that rely on good assessments rely on good clinical judgment. And so you put that all together, and then I think everyone is happier and also absorbs more because after you just tune out at a certain point, right? Who doesn't? So I think that's helpful.
Perfect. So at this point in the week, you've set expectations in a proactive way. You've given some real-time feedback, either proactively or during the discussion on rounds. Do you give time for structured feedback, either for your trainees or for your fellows? And if so, what does this look like?
The answer is, I try. I try very hard to do it. It's hard. I think we live in a world where feedback is so mandatory. It's almost like too much feedback is like no feedback. It almost becomes perfunctory. Like everyone needs feedback at the beginning. They need feedback at the middle. They need feedback at the end. But sometimes it's just, gosh, there's only so many times you can sort of say the same thing. Like, yeah, you are actually doing a great job. And you're still doing a great job. And you've done a great job at the end. So it's hard. Honestly, I think some of us just get burned out by all the feedback. But I try very hard to give timely feedback. And sometimes it's on rounds, like, we're rounding in the morning. The ID consultant had said the night before in their note at like 4 or 6 p.m. to do X, Y, or Z. I come in around in the morning, it hasn't been done. And that would be a rounds moment. That wouldn't even be a private moment because you know what? There's a lot of people involved. There's maybe the medical student, and then there's the intern, and then there's the resident. So if the intern's presenting the plan and they mention an antibiotic, when I know that a note from 12 hours prior said a different, I'll say, wait, why wasn't this found out? This is essential attention to detail. You want your mom to get a certain level of care, and this is the kind of care the patient should get. So I try to make feedback it's not personal. It is about the patient. So if our goal is to take great care of patients, has this action met that goal? And if it hasn't, why hasn't it? What are we going to do better in the future? So sometimes it'll be on rounds. Sometimes if I feel like a resident is truly struggling, I think it's hard sometimes when it comes from the attending physician, and sometimes they have a closer, maybe even more casual relationship with the fellow. I might say to the fellow, listen, you talk to them, give them really some constructive feedback, how they're presenting, how their systems are going for getting their checklists in place, et cetera, because they're missing things. And then if it doesn't get better in a few days, let me circle in. So it's a little bit of good cop, bad cop, but I think it works better sometimes coming from someone closer in training who has more experience than the attending. So I think timely is important, specific is important. The focus on the goal, which is patient care, not whether you're good, bad, or indifferent, because that doesn't matter. All that matters is taking care of the patient. I think that when then things start to get better, you absolutely acknowledge it. And I often publicly acknowledge it on rounds. Like, that was an awesome call yesterday. The consultant left some recommendations that made no sense. You tracked them down. You had them edit their note. You implemented the findings. That really helped the patient. And I think that good feedback is as critical as bad. And I love to give it. And then the final piece is, sometimes having the fellow as the intermediary when there's more feedback needed sometimes helps.
Dr. Michelle Kittleson, what a great conversation today. I'm really thrilled to speak with you. So much of the things that you talk about on rounds, the adult heart failure service, actually just translate over to the PICU really, really well. I know I've learned a lot. I'm sure, Alice, you would say the same. Tell us about your book, Mastering the Art of Patient Care. Where can we find it?
Oh, thank you so much. I'm so excited about this book. A little vulnerable too, I suppose, because I put all my mistakes in there so everyone can learn from them. But really what it takes us through is my advice on how to get the most out of medical school, how to get the most out of training, and how to get the most out of your career in medicine. How do you take care of your team? What's the art of the consult? What do you do when you have to have a tough conversation with a patient? And so I envision some people might read the book from start to finish, and I'll be very grateful if you do. And other people might just flip through and say, gosh, I'm having a really tough time as a woman in medicine. Well, look here, there's a chapter called Being a Woman in Medicine. In parentheses, men, don't skip this chapter, exclamation point. So I think I look at it almost like a handbook. Like sometimes you're lucky, like I've been, to have extraordinary mentors, a cabinet of mentors that I can go through with various problems. But if you don't, then at least you'll have a book that might have some of that mentoring advice in it. You can find it at the Springer website. Go to the Springer website, search for the title, and buy a copy for you and your favorite trainee.
Excellent. Well, thank you so much for joining us today. Is there anything you'd like to emphasize from today's conversation before you sign off, or do you feel like we've been complete?
Well, I'd like to say that I think pediatricians are the heroes of the universe because you engage in wild game wrangling on a daily basis and you understand how to prescribe things in like mils per kg or megs per kg, which I don't even understand. And so thank you for doing everything you do.
Well, thank you.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.